Good morning, good afternoon, and good evening, ladies and gentlemen. Today it's my pleasure to present the study entitled of the growth recovery among Asian children with perinatally acquired HIV infection on first-line combination antiretroviral therapy. And my name is Dr. Tavitiya Sudjaritruk from the Faculty of Medicine, Chiang Mai University, Chiang Mai, Thailand. As you may know that the growth failure is a key concern for children living with HIV because it can result in worsening growth retardation as well as delayed puberty during adolescence and adulthood. In the previous study in sub-Saharan Africa countries, they found that 50% of children living with HIV were underweight, and about 48 up to 73% of this population were stunted prior to ART initiation. And the ART has a positive effect on the weight and height growth. The growth parameters show that it improved and reached the reference standards for age and gender after ART initiation. However, there are so limited data regarding growth recovery after ART initiation among Asian children living with HIV. That's the reason why we conducted this study, which aimed to determine the incidence and predictors of growth recovery among Asian children living with HIV on the first-line combination antiretroviral therapy. This is a retrospective cohort study which conducted in children living with HIV in the TAPCOT database. We enrolled children aged below 19 years, had perinatally acquired HIV infection, had been initiated first-line combination antiretroviral treatment at the age below 10 years, and received first-line CAR for at least 1 year. For the outcome definition, we use the WHO growth chart as the standard reference. The growth failure, the underweight defined as weight for a Z-score below or -2 standard deviation, and stunted defined as the height for a Z-score below -2 standard deviation. For the growth recovery, the weight and height recovery were defined as the transition of the weight for a Z-score or height for a Z-score from below -2 standard deviation to equals or greater than -2 standard deviation. In this study, we use a Kaplan-Meier estimate to describe the cumulative incidence of growth recovery. And we also use the Cox proportional hazard regression to identify the predictors of the growth recovery. The baseline in this study defined as the time of the first-line combination antiretroviral treatment initiation. For the results, in this study, there were 2,493 children living with HIV eligible. And at the baseline or at the time of first combination antiretroviral treatment initiation, you can see in the table that 53% were male. The median age were 3.5 years. Nearly 90% of them were on an NNRTI-based regimen. 46% of them had advanced HIV clinical stage, and about 32% of them had CD4 cell count below 200 cells per cubic millimeters. Interestingly, at the baseline, we saw that 49% of our children living with HIV were underweight, 58% were stunted, and about 42% of them had both conditions, underweight and stunt. After the first-line combination antiretroviral treatment initiation, you can see that about 75% of our population had weight recovery with a median recovery time of 1.1 years. And about 67% of them had height recovery with a median recovery time of 2.6 years. The predictors of the weight recovery include the female sex, younger age, greater weight for a Z-score and height for a Z-score, and advanced HIV clinical stage at the first line combination antiretroviral treatment initiation. For the predictors of height recovery, we found that younger age, greater weight for a Z-score and height for a Z-score at the time of first-line combination antiretroviral treatment initiation, as well as the using of PI-based regimen, were associated with the height recovery in our population. In conclusion, approximately half of our Asian children living with HIV had growth failure at the time of first-line combination antiretroviral treatment initiation. And after the first-line CAR initiation, 3/4 of our population demonstrate weight recovery, and 2/3 of them demonstrate height recovery. We think that Early CAR initiation at the time that children have less severe growth failure are important predictors of growth recovery in our population. Finally, I would like to thank the Treat Asia Pediatric HIV Network for supporting conducting this study. Thank you so much.
Thank you, Dr. Tavitiya, for that talk. Please remember to type in your questions into the chat box, and Carol will be looking out for them. If Dr. Tavitiya, are you on the line?
Yes, I'm here.
Okay, as we wait for others to type in their questions, I'll just ask you one or two questions.
Okay.
So how does this growth recovery, the growth of these children that are living with HIV, even after they've recovered, how does it compare with the growth of the children that are not living with HIV? Firstly, before they reach the age of 10, and also after, you know, when they enter adolescence, where we know that growth spurt starts happening. How does that compare?
Yeah, because in this study we did not have the data of the uninfected HIV children and adolescents, but when I saw that at the time of they have the weight and high recovery, they still have the weight for AC score and high for AC score nearly -2 or during in between -1 and -2. So I think it's still under the normal range when compared to HIV uninfected children and adolescents.
Okay. And then it was also interesting to see that being female was associated with weight recovery, but not associated with height recovery.
Yes.
Do you have any idea as to why that may be?
Yeah, it's quite interesting to me as well. But because I did not explore the underlying of this yet, but yeah, I still cannot answer this question right now because yeah, I have to find out more information.
Okay, thanks for that. Does anyone want to chime in before I ask my next question? Please feel free to unmute.
Hi, this is Carly Williams. The recovery is great, but only 3/4 and only 2/3. Do you have any ideas for what we can do for the other children who are not recovering? And when you say not recovering, that means not getting better than -2 Z-score. Yeah, so they're pretty small if they're at -2. Is that right?
Yeah, for this study, we use the cutoff to define the recovery as -2. So I think the next step, I may be looking for those who are not recover with this definition to see how much the change from baseline, for example, for the percent change from baseline, whether or not it have the so for example, 10% change or 20% change from baseline for those who are not have the weight and high recovery to see whether or not they have the show the improvement of the weight and height or not. But for this study, we use the higher solid cutoff to stick with the -2 standard deviation as the cutoff to determine the growth failure or growth recovery. Does that answer your question?
You know, it's also trying to think, the early start, that's great. You know, we want the kids to start earlier, but wondering what else we might do for those that are starting later or who are not recovering. So, you know, what might we think of as the next approaches for those who fail to recover?
Oh, okay. So I think because in this study we found that early CAR initiation is a good predictors for the weight and height recovery, as well as we found that less severe growth failure at the baseline also associated are important predictors of the growth recovery as well. And the PI-based regimen, I think because we use the PI-based regimen compared to the NNRTI-based regimen, so I think the high potent CARD regimen is also associated or important predictors of the growth recovery as well. So I think this is the key point of this study. If we can early initiated CARD as well as start with a high potent CARD regimen at the time that the children still have less severe growth failure is the good predictors for the growth recovery among this population.
Thank you very
Thank
much.
you.
Thank you, Dr. Tavitiya, for that.